Good morning. Welcome to this class. Ketogenesis and diabetic ketoacidosis are the main themes, and we'll come across all the details of this subject. Ketone bodies, they are the alternative fuel for the cells. Usually we know that the main fuel for the cells is glucose, isn't it? But sometimes our cells will be shifting to prefer ketone bodies also. And you know pretty well that the nervous tissue is fundamentally dependent on glucose, and cardiac muscle is basically dependent on glucose, and renal tissues will be fundamentally dependent on glucose. But sometimes they will shift their preferences to ketone bodies in extraordinary conditions when glucose is not available. Liver mitochondria have the capacity to convert acetyl-CoA that is derived from fatty acid oxidation into ketone bodies. You know pretty well, fatty acid oxidation finally gives acetyl-CoA, and that acetyl-CoA can be converted into ketone bodies by the liver mitochondria. So the ketone bodies are three: acetoacetate, beta-hydroxybutyrate, and acetone. Acetone is volatile substance. It cannot be further metabolized. It's a side product. So basically, the keto acids are acetoacetate and beta-hydroxybutyrate. So two functional ketone bodies are organic acids. That is acetoacetate and beta-hydroxybutyrate. In the Viva, they will ask about this. And in the theory examinations also, they will be frequently asking about ketone body, ketogenesis. So remember this with certainty so that you can easily get over the Viva and the theory also. So two functional ketone bodies are organic acids, acetoacetate and beta-hydroxybutyrate. So they are transported through blood to the peripheral tissues where they will be converted to acetyl-CoA. Then it can be oxidized through TCA cycle that you know pretty well. Ketone bodies are important sources of energy for peripheral tissues because these are all the things you have to remember. Why ketone bodies are important sources of energy for peripheral tissues? Only because they are soluble in aqueous solution and hence need not be incorporated into lipoproteins or albumins for its carrying into the peripheral tissues. So no carrier protein is needed. So no lipoprotein is needed. No albumin is needed. So they are soluble, just perfectly soluble in aqueous solution. And that's why they need not be incorporated into lipoproteins or albumin. They are produced in the liver during the periods when the amount of acetyl-CoA present exceeds the oxidative capacity of the liver. So acetyl-CoA will be converted into ketone bodies. So they are used in proportion to their concentration in the blood by extrahepatic tissues like skeletal muscle, cardiac muscle, and renal cortex. Normally, brain depends on glucose, you know pretty well. But even the brain can use ketone bodies to meet the energy needs if blood levels of ketone bodies exceeds. So ketone bodies spare glucose, and this happens in prolonged periods of fasting or starvation. So you know pretty well our separate Andhra state was achieved by the fasting of Potti Sriramulu. So Potti Sriramulu, when started fasting, nobody thought that he will fast until death, but he decided himself and he will declared that he will fast until death, unless otherwise the separate Andhra state is given by bifurcating the Tamil Nadu. So Telugu speaking people should have Andhra Pradesh. That is his idea. So he fasted for over a period of 51 days, and by that time all the ketone bodies entered the blood, and as far as the brain can utilize, kidney can utilize, and the skeletal muscle and cardiac muscle can utilize, it's okay. But beyond that, it is swarmed the blood, and the acid pH was finally established at the expire. So normally brain depends on glucose, but even the brain can use ketone bodies to meet energy needs if blood levels of ketone bodies exceeds. So ketone bodies spare glucose, and this happens in prolonged periods of fasting or starvation. During a fast, liver is flooded with fatty acids mobilized from adipose tissues, and that results in elevated hepatic acetyl-CoA production. That is primarily by fatty acid degradation. This inhibits pyruvate dehydrogenase and activates pyruvate carboxylase. Oxaloacetate is produced and utilized by the liver for gluconeogenesis rather than for tricarboxylic acid cycle. Therefore, acetyl-CoA is channeled into ketone body synthesis. Fatty acid oxidation decreases NAD plus to NADPH ratio, and rise in NADH shifts oxaloacetate to malate. So this pushes acetyl-CoA away from gluconeogenesis and into ketogenesis. So the synthesis of beta hydroxy, beta methyl butyryl CoA, HMG-CoA. The first synthetic step is formation of acetyl-CoA, which occurs by reversal of thiolase reaction of fatty acid oxidation. Mitochondrial HMG-CoA synthase combines a third molecule of acetyl-CoA with acetoacetyl-CoA to produce HMG-CoA. So the first synthetic step for HMG-CoA is formation of acetyl-CoA that occurs by reversal of thiolase reaction of fatty acid oxidation. Second thing is mitochondrial HMG-CoA synthase is the enzyme that combines a third molecule of acetyl-CoA with acetoacetyl-CoA. Then the resultant product is HMG-CoA. HMG-CoA synthase is the rate limiting step in the synthesis of ketone bodies. It is present in significant quantities only in the liver. So two acetyl-CoA will combine together, and they will produce acetoacetyl-CoA, and that will give beta hydroxy beta methyl butyryl CoA, that is HMG-CoA, and from there HMG-CoA lyase will give acetoacetate, and this acetoacetate will be giving acetone in one side and beta hydroxybutyrate in the other side. HMG-CoA is cleaved to produce acetoacetate and acetyl-CoA. Acetoacetate can be produced to form beta hydroxybutyrate with NADH as hydrogen donor. Acetoacetate can spontaneously decarboxylate in the blood to form acetone that cannot be further metabolized. Acetone is a volatile, biologically non-metabolized product that can be released through breath expiration. The generation of free CoA during ketogenesis allows fatty acid oxidation to continue. NAD plus to NADH ratio is slow during fatty acid oxidation. Hence, beta hydroxybutyrate synthesis is favored. That is the favorable step. And the use of ketone bodies by peripheral tissues, we call it as ketolysis. Although liver constantly synthesizes low levels of ketone bodies, their production becomes much more significant during fasting when ketone bodies are needed to energy to peripheral tissues. Beta hydroxybutyrate is oxidized to acetoacetate by beta hydroxybutyrate dehydrogenase producing NADH. Acetoacetate is provided with a CoA molecule taken from succinyl-CoA. By succinyl-CoA, acetoacetate-CoA transferase. That's known as thiophorase. It's a reversible reaction. The product acetoacetyl-CoA is converted to 2-acetyl-CoA. So this is how from the liver, the free fatty acids will enter the liver and acyl-CoA and beta oxidation takes place, acetyl-CoA, and then it will be converted to HMG-CoA, and then acetoacetate will be formed. And from acetoacetate, beta hydroxybutyrate will form in the liver. And this beta hydroxybutyrate will be transferred into muscle. And acetoacetate also will be transferred into the muscle. So from beta hydroxybutyrate, acetoacetate can be generated. And from here, acetoacetyl-CoA and then acetyl-CoA, and that will go into oxaloacetate and citrate and succinyl-CoA to succinyl. All this, extrahepatic tissue muscles metabolism. So extrahepatic tissues, including brain, efficiently oxidizes acetoacetate and beta hydroxybutyrate. When the emergency comes, when there is no blood glucose levels in severe starvation, then there is no other way for the brain but to accommodate with beta hydroxybutyrate, ketone bodies. Liver produces ketone bodies, but it cannot utilize because it is not having thiophorase enzyme. Ketolysis cannot occur in cells lacking mitochondria like RBC. Excessive production of ketone bodies takes place in diabetes mellitus. When the rate of formation of ketone bodies is greater than the utilization, their levels begins to rise in the blood, causing ketonemia. So when the blood is swarmed with the ketone bodies, it has to get automatically into the urine, that is known as ketonuria. So this is seen in most of the uncontrolled type 1 main insulin dependent diabetes mellitus is type 1. And in type 2 diabetes mellitus, when it is badly controlled. In diabetic individuals with severe ketosis, urinary excretion of ketone bodies may be as high as 5,000 milligrams in 24 hours, and blood concentration may reach 90 milligrams per deciliter. Usually, it should be less than 3 milligrams per deciliter in normal individuals like you and me. Symptoms of diabetic ketoacidosis is fruity odor of the breath due to excessive production of acetone. You know pretty well, acetone is just like the nail polish remover, and everyone might have experienced the smell of acetone, characteristic smell of acetone, that is fruity odor. So symptoms of diabetic ketoacidosis is fruity odor of the breath due to excessive production of acetone. Elevation of ketone bodies in blood results in acidemia. The carboxyl group of ketone bodies has a pKa of 4. Therefore, each ketone body uses a proton as it circulates in the blood and lowers the pH of the blood. So acidemia will take place. Excretion of glucose and ketone bodies in urine results in dehydration and decreases the volume of the plasma. That is the main pathetic stage in diabetic ketoacidosis. So excretion of glucose and ketone bodies in urine results in dehydration and decreases the volume of plasma. So remember, these are the two classical end results. Excretion of glucose and ketone bodies in urine results in dehydration and decreases the volume of plasma, hypovolemia. The net result is increased number of hydrogen ions in the decreased volume of plasma, resulting in severe acidosis. When the volume is decreased, it will reflect as severe acidosis. It can also happen in fasting, but urine is negative for glucose. So this is the only difference between diabetic ketoacidosis and starvation ketoacidosis. In an individual who is starving, You cannot find glucose in his urine sample. But whereas the fellow who is suffering with diabetic ketoacidosis, you will find the large amounts of glucose in the urine sample collected from that individual. So this is most important. Whenever somebody is doing fasting for some achieving some political gain, so the government will send a doctor and a nurse and a technician to that pandal where that fellow is doing fasting until death. So what we have to do is, as a doctor, we have to go and request him humbly and in a palatable manner. We should not order him because he may be a great person after some time. So we have to ask him to kindly give a small amount of his urine sample, and the technician will collect that small amount of urine. Just 5 ml of urine is sufficient. And what we have to do, we have to supersaturate the urine with ammonium sulfate so that any amount of proteins present may be precipitated. And then we have to add 2-3 drops of sodium hydroxide, and then we have to add liquor ammonia. And immediately the violet color will the, the color will appear just like rose petals. So the rose pink color will appear at the interface between the urine sample and the reagent supplied. So this is the classical Rotharas test. So the classical Rotharas test should be done even in the fasting panel of that man, and we can submit the report online to the, it's a hotline to the government. If ketone bodies are present, this is a sensitive test. The Rotharas test is a sensitive test to find out acetone and acetoacetic acid in the urine sample. Then immediately the person should be shifted back into hospital where he should be taken care of the hypovolemia and the hyperglycemia, and insulin also should be given. So excretion of glucose and ketone bodies in urine results in dehydration and decreases the volume of plasma, and net result is increase in number of HIRs and a decreased plasma volume resulting in severe acidosis. It can also happen in fasting, but the urine is negative for glucose. So liver mitochondria can convert acetyl-CoA of fatty acid oxidation into ketone bodies, acetoacetate and beta hydroxybutyrate. So these are the acetone, acetoacetate and beta hydroxybutyrate are the ketone bodies. The peripheral tissues having mitochondria can oxidize beta hydroxybutyrate to acetoacetate, which can be converted to acetyl-CoA producing energy. Unlike fatty acids, ketone bodies can be utilized by brain and important during fasting stages. Liver lacks ability to degrade ketone bodies and cannot use them even though it produces ketone bodies. It's only for peripheral tissues to utilize ketone bodies. Ketoacidosis occurs when the rate of formation of ketone bodies is greater than the utilization, as in type 1 mostly, and in type 2 badly regulated diabetes mellitus. So diabetic ketoacidosis is a state of absolute or relative insulin deficiency aggravated by ensuing hyperglycemia, dehydration and acidosis, producing derangements in intermediary metabolism. DKA is far more characteristic feature of type 1 diabetes mellitus than type 2 diabetes mellitus. Class. So lab definition of diabetic ketoacidosis is the glucose level in blood should be more than 250 milligrams per deciliter, and blood pH should be less than 7.3, and the ketones in serum is more than 5 milliequivalents per liter. So please remember, the lab definition is most important for you to face your Viva examination and even the theory examination also. So the blood glucose level is more than 250 milligrams per deciliter and blood pH is less than 7.3 and ketones in serum is more than 5 milliequivalents per liter. Diabetic ketoacidosis is reported in 2 to 5% of known type 1 diabetic patients in industrialized countries, while it occurs in 35 to 40% of such patients in Africa. The people who face a lot of famine, poverty, starvation in childhood, they are more likely to develop diabetic ketoacidosis and even diabetes also in adult stages. So the African people, Somalia, Ethiopia, and all these places, the people are very much starved during their childhood. So diabetic ketoacidosis at the times of first diagnosis of diabetes mellitus is reported only 2 to 3% in Western Europe, but is seen in 95% of diabetic children in Sudan. And similar results were reported from other African countries. The basic underlying mechanisms are absolute deficiency of circulating insulin. So when the beta cells of pancreas is not at all producing any insulin, we call it as absolute deficiency of circulating insulin. Secretion of insulin, counter-regulatory hormones. So you know pretty well, the glucose will be elevated by glucagon, adrenaline, cortisol, and growth hormone. These are all the things that will counter the activity of insulin. So secretion of insulin counter-regulatory hormones. So here in the examination, they will ask, what are the counter-regulatory, insulin counter-regulatory hormones? You have to tell glucagon, adrenaline, cortisol, and growth hormone. This can be given for 2 marks, ultra short question also. So you are awarded half mark for all these 4 points. You have to remember it. Not only just to get over the biochemistry exams, lifetime we have to remember this. So the basic underlying mechanisms are absolute deficiency of circulating insulin, secretion of insulin counter-regulatory hormones like glucagon, adrenaline, cortisol, and growth hormone. So this is a very good picture. But remember the balance, homeostasis of normal blood glucose levels. You know, normal blood glucose level is just between 90 milligrams to 100 milligrams, 90 milligrams per deciliter. That is the normal blood level. And it should not be going into imbalance below that up to 60 milligrams. And it should not increase up to 225 milligrams. That is hyperglycemia. So hypoglycemia is below 90 milligrams and up to 60 milligrams per deciliter is gross hypoglycemia, where brain death will take place. You have to fear that. And hyperglycemia is anything around 225 milligrams is hyperglycemia. So when imbalance of is there below 90 milligrams, the stimulus is declining blood glucose levels. Then the pancreas will get the stimulus and glucagon secretion will take place and it will stimulate the glycogen breakdown and all the glycogen will be broken down into glucose. You know pretty well, large number of glucose molecules should be packed down into glycogen and then glycogenolysis will take place under the influence of glucagon. So blood glucose level rises to normal range and the fellow will survive. So the stimulus of rising blood glucose will lead to the imbalance and pancreas will produce insulin and it will stimulates the glycogen formation and the tissue cells will take up the glucose and slowly the hyperglycemia will be balanced. So blood glucose level falls to normal range. So this is how the balance of hyperglycemia and hypoglycemia will be taken care by the body. And the same thing also here. So the fat cells, insufficient or absent insulin will result in the lipolysis, liberating the glucose, glycerol, and fatty acid, and they'll escape out from the cell, and the fatty acids will be converted into ketone bodies, and it will be utilized for glycogenolysis, gluconeogenesis, and ketogenesis. And the glycogen chain will be converted into glucose, and the glucose production will be donated from amino acids, glycerol, and other substances. And finally, this is how the insufficient or absent insulin, diabetic ketoacidosis will result. So this leads to disturbances in the physiological processes. The glucose utilization will be decreased and hyperglycemia results. So glucose cannot enter into the cells because the carrier is insulin. So insulin dependent cells type 2 will not be facilitating the entry of glucose into the cells. And proteolysis, amino acids will be coming down due to the breaking of the proteins in the muscle. Glutamine and alanine will be coming down into the blood. You know, alanine glucose cycle. Lipolysis, glycerol and fatty acids will escape the cell, and glycerol will be taking part in the glucose production, and free fatty acids also will be oxidized. Glycogenolysis, breakdown of muscle glycogen and production of lactate. And gluconeogenesis, glutamine and alanine and glycerol and lactate are the precursors gluconeogenesis. So glucose production from the non-glucose substrates is known as gluconeogenesis. So glutamine, alanine, glycerol, and lactate are the precursors. So you have to be able to tell all the four to get 2 marks in ultra short question. So gluconeogenesis will be from glutamine, alanine, glycerol, and lactate. So hyperglycemia will be leading to serum osmolality, and this serum osmolality will increase the insulin resistance, and that will increase the hyperglycemia, and hyperglycemia worsens. And the decreased insulin leads to increased lipolysis, and that leads to increased production of ketone bodies, and that leads to ketonemia, and ketone anions will deplete the alkali reserves, and that leads to kusumal respiration. And the dehydration is the ultimate result. So hyperglycemia leads to hyperosmolality, and that leads to increased urination, and nausea and vomiting leads to further water loss, and decrease of the renal blood flow leads to GFR decrease, and hypovolemic shock results. Electrolyte imbalance results in the loss of potassium and blood urea nitrogen. So this is the simple representation. So metabolic acidosis, how it comes. So pathogenesis of diabetic ketoacidosis, decreased vascular resistance, nausea, vomiting, abdominal pain. So infection is the main reason, that is the initiating or triggering factor. When a fellow is subjected to infection, then you should not be going on depending on oral hypoglycemic agents. We have to depend on, we have to immediately put him on insulin. So whenever a fellow comes with a state of infection, we have to, cellulitis, most important example. If a person comes with cellulitis, and if we find that he is having hyperglycemia, and the urine is positive for glucose, and the ketone bodies are present in the circulating blood, then immediately, without any thinking, we have to put him on insulin. Otherwise, life cannot be safe. And infections like cellulitis and pneumonia, quite common in this winter season and in the rainy season, especially the small children and old people. So pneumonia is a threatening, life-threatening infection. And upper respiratory tract infection is most commonly affecting the small children and old age people. And we do not have the inadequate use of insulin, and most of the people will not have sufficient amounts of insulin in his refrigerator. So they'll be telling their children repeatedly, but the children will be very busy. So they will tell definitely I will bring, but they will forget at the end of the day. So inadequate use of insulin may be also due to the carelessness of the patient. రోజు ఎవడు ఇంజెక్షన్ చేసుకుంటాడు, చాలులే పర్వాలేదు ఇవాళ నేను ఎక్కువ అన్నం తినలేదులే అని he will just satisfy himself, but that's not at all the answer. So not taking insulin, forgetting the insulin dose, or lack of insulin reserves in the fridge to be utilized by the patient. Emotional stress, that is the most common problem. The people working in um, the very fast areas, so they will not be calm. They will be having emotional stress in the office. And the people who are unnecessarily using drugs, corticosteroids. So people will be taking corticosteroids for body pains, body pains. So PMP doctors, they'll be fooling the patients by administering corticosteroids. So the corticosteroids will unnecessarily make them feel better, but they'll be going into um, hyperglycemia. So antihistaminics, they will be also given by the people who do not have the knowledge. And thyroid diuretics. And you know pretty well about the pancreatitis. So pancreatitis, maybe pancreatic small bubble-like things will be presenting, and pancreatic tumors will be present, and the people who are suffering with alcoholism will be having pancreatitis. So alcoholic pancreatitis. So in such conditions, the pancreas will be having low amounts of insulin secretion. The symptoms of diabetic ketoacidosis are classic symptoms of hyperglycemia in a short period of time. Those are polyuria, polydipsia, hyperphagia, weight loss and thirst. So polydipsia, they'll be having thirst. They'll be keeping a glass of water right in front of them on their working table. ఆ వర్కింగ్ టేబుల్ మీద ఒక చిన్న గ్లాస్తో నీళ్లు పెట్టుకుంటారు. ఆ నీళ్ల మీద మూత కూడా పెట్టుకోరు, ఎందుకంటే దే విల్ బి ఫ్రీక్వెంట్లీ నీడ్ టు టేక్ ద వాటర్. అందుకోసం మూత పెట్టుకుంటే మళ్ళీ తీయడం ఎంత పెద్ద టైం పెట్టేస్తుంది, గ్లాస్ మీద మూత కూడా పెట్టుకోరు. అందుకే మోస్ట్ ఆఫ్ ద టైమ్స్ the medical representatives, what a fascination to donate half a dozen of the glass slides. So they will be keeping it, remembering that they should take frequently the water. So polyuria, they will be frequently visiting the attached bathroom. So that is polyuria. Why polyuria? The increased amounts of glucose escaping through the urine will unnecessarily increase the blood specific, the urinary specific gravity. And to neutralize the increased urinary specific gravity, large amounts of water should be mixed into that thick concentrated urine. So that will lead into polyuria. And polydipsia, because we are losing large amounts of water, we have to replenish it by taking frequent amounts of water. That is polydipsia. There will be weight loss because the body will be melting down like wax. So the fat will become very loose. They will be going on increasing their belt. You know, belt will be having 6 or 7 holes. And initially when he brought the belt, and he bought the belt, he used to put it on the last terminal point. But as he is losing more and more amount of body, he may be tightening until he comes to the last hole on the belt. So remember, if this happens to any one of our people in the house, we have to find out whether he is suffering with relative insulin deficiency leading to diabetes. So other symptoms are general weakness. Initially, he may be carrying large amounts of weights when he is coming from the office to the home, but he may be refusing to carry any more loads. నేను తేనలే, నేను 10 కేజీలు బియ్యం తేను, నేను 4 కేజీలు షుగర్ తేను, నాకు ఓపిక లేదు, నాకు నీరసంగా ఉంది అని చెప్పేస్తుంటాడు. సో జనరల్ వీక్నెస్ విల్ బికమ్ వెరీ problematic for him. Malaise, he will feel very bad of doing the things. చాలా నీరసం అయిపోతున్నాను, నాకు ఒంట్లో బాగుండడం లేదు. మలైస్ మీన్స్ ఒంట్లో బాగుండడం లేదు అనే ఫీలింగ్. లెథార్జీ, వీక్నెస్, బద్ధకం, లెథార్జీ. అలా కూర్చొని పేపర్ తిరగేసి చదువుతాడు, కానీ కుర్చీలో కూర్చొని లేచి ఏదో పని చేస్తాను, అరే పాపం భార్య అడుగుతుంది కదా అని కన్సిడర్ చేయడు. లెథార్జీ, చాలా నీరసం అయిపోతాడు. సో నాసియా అండ్ ఓమిటింగ్, మాట్లాడితే ఓమిటింగ్ సెన్సేషన్, నాసియా, అలా ఓమిటింగ్ వచ్చినట్టు ఫీలింగ్. అండ్ అబ్డామినల్ పెయిన్ ఇస్ క్లాసికల్. దర్ విల్ బి పెర్స్పిరేషన్, అలా చెమటలు పట్టేస్తూ ఉంటాయి, ముదురు అంతా చెమటలు పట్టేస్తూ ఉంటుంది, బాడీ అంతా చెమటలు పట్టేస్తూ ఉంటుంది. అలా ఫ్యాన్ దగ్గరికి పెట్టి వేసేసుకుంటూ ఉంటాడు. డిస్టర్బ్డ్ కాన్షియస్నెస్ అండ్ కన్ఫ్యూజన్. వలన ఏదైనా అడిగితే విసుక్కోవడం, కసురుకోవడం, ఏదైనా అడిగితే సరిగ్గా గుర్తు చేసుకోలేకపోవడం. సార్ నేను మీకు 100 రూపీస్ ఇచ్చానంటే, ఎప్పుడు ఇచ్చావు, ఎవరికి ఇచ్చావు, నా తాతకి ఇచ్చావా, నా తండ్రికి ఇచ్చావా అని కసురుకుంటాడు అనమాట. There will be confused state. He cannot do a simple calculation. So he will be in a confused state of affairs. So symptoms of underlying infections like pneumonia and cellulitis and upper respiratory tract infection, any infection, so will be there. Pyogenic infections on the skin, diabetic ulcers will be there, diabetic tumors will be present. So these are the problematic things. Cellulitis is most common. So infections, in other conditions, fever, abdominal pain, dysuria, painful menstruation, chest pain, all will be. And general signs are ill appearance. He will be appearing not as a common healthy man. Ill appearance and disturbed consciousness. చిరాగ్గా పరాగ్గా ఉంటాడు అన్నమాట. అండ్ సైన్స్ ఆఫ్ డిహైడ్రేషన్, స్కిన్ ఇస్ డ్రై, హాట్, ఫ్లష్డ్ అండ్ లాస్ ఆఫ్ స్కిన్ టర్గర్. సో స్కిన్ యూజువల్లీ హ్యావ్ ఇలా స్ట్రెచబుల్గా ఉండాలి కదా, సో స్కిన్ టర్గర్ విల్ బి డిప్లీటెడ్. టంగ్ ఇస్ డ్రై అండ్ దట్ ఈస్ represented as woody tongue. Eyes are sunken, dark circles under the eyes will be seen. And the vital signs, tachycardia, hypotension, tachypnea. Tachycardia, number of beats per minute may be increasing more than 88 to 96 per minute. Hypotension, blood pressure will be low. Tachypnea, the 24 respirations per minute will be more than that, even up to 32 per minute. And the specific signs are ketotic breath, strong fruity breath odor, similar to nail polish remover or acetone smell. Acidotic breath, that is Kusumal's respiration. Deep and rapid breath is known as Kusumal's respiration. Abdominal tenderness is classical. So symptoms of acidosis are in the central nervous system, headache, sleepiness, confusion, loss of consciousness, coma. That's ultimate central sign. The muscles, seizures, weakness of muscles, intestines, diarrhea and pain abdomen will be common. In respiratory system, shortness of breath, coughing, and in the heart, arrhythmias, increased heart rate, and in the gastric, nausea and vomiting. So any number of times you have to memorize this symptoms of acidosis. Central symptoms are headache, sleepiness, confusion, loss of consciousness, and coma. And respiratory symptoms are shortness of breath and coughing. And muscular symptoms are seizures and weakness. Intestinal symptoms are diarrhea. And gastric symptoms are nausea and vomiting. In the heart, arrhythmias and increased heart rate. Remember this. You should suspect diabetic ketoacidosis if a diabetic patient presents with dehydration, acidotic breath, Kusuma's breath, with a fruity smell, acetone breath, abdominal pain or distension, vomiting, an altered mental state ranging from disorientation to coma. So already he is a diabetic person, and if he is presenting with dehydration, Kusuma's breathing with a fruity smell of acetone, abdominal pain or distension, vomiting, or altered mental status ranging from disorientation to coma. And if some of the persons accompanying him tells you that he is already a diabetic person, then you have to suspect diabetic ketoacidosis. So high white cell count. You know pretty well that high WBC count will be present in the only in the infections. So in the state of infections, you'll find more than 10,000 WBC in count. But even without any infections, high WBC count will be seen, white cell count will be seen. So, one, blood urea nitrogen may be elevated with the prerenal azotemia secondary to dehydration. And creatinine, some masses may cross-react with ketone bodies, so it may not reflect a true renal function. Serum amylase, it's often raised when there is abdominal pain. A diagnosis of pancreatitis may mistakenly be made in DKA. The main lines of management include primary assessment, volume status and degree of dehydration, blood pressure and cardiac condition, degree of consciousness, degree of acidosis, precipitating disease. So blood glucose, we have to use glucometers every hour. Emi noppundadu, emi kashtam undadu. If we do it carefully, how to use that blood from the peripheral circulation. So electrolytes and pH every 4th hourly, and urine for glucose and ketone bodies every 4th hourly. So we have to do this urinary analysis. So general measures, airway should be taken care of, and oxygen insufflation should be given if needed, and IV line should be maintained. Urinary Foley's catheter should be given if the patient is in shock and if he cannot pass urine. Otherwise, what will happen? The lower abdomen will distend, suprapubic distension will be taking place, and the bladder will be distending if we do not take care of it. That's why, if he is an unconscious patient, we have to put immediately the urinary Foley's catheter. So continuous bladder drainage, we call it CBD. NGT, nasogastric tube, should be given to avoid gastric dilatation and the protection from aspiration. So unnecessarily he will aspirate the gastric contents into the respiratory tract, into the trachea, if we just leave it like that. So to avoid gastric dilatation, we have to put him on nasogastric tube, continuous Stiles tube, continuous bladder drainage. These are the two mandatory things when we admit a patient of diabetic ketoacidosis in coma. So thrombosis prophylaxis should be taken care of by giving 5,000 units of heparin subcutaneously every 12 hours. So once in 12 hours, that is 2 times in a day, we have to give 5,000 units of heparin. Empiric use of third generation cephalosporins as antibiotics should be given. So we have to give cephalosporins as antibiotics, third generation. And specific measures are successful therapy of hyperglycemia crisis requires the administration of fluids. So we have to correct the volume deficit and hypotension by giving correct volume administration of IV fluids, and improve tissue perfusion, improve insulin sensitivity. So insulin. So counter-regulatory hormones will be there. I told you about the glucagon, steroids, all these things. So the three measures, you have to correct the volume deficit and hypotension. Second measure is improve the tissue perfusion. Third is improve the insulin sensitivity. Insulin counter-regulatory hormones should be there. We have to take care of it. And the fourth one is improve glomerular filtration rate by increasing the excretion of large amounts of glucose in urine, and it clears the hyperketonemia. And you have to correct the metabolic acidosis. So by giving insulin, reversal of metabolic abnormalities will take place. We can correct the hyperglycemia. We can inhibit ketogenesis, and the potassium, the prevention, it prevents the complications associated with the hypokalemia. So the expected volume deficits calculated as 5 to 10% of body weight in DKA and 15% of body weight in non-ketotic hyperosmolar hyperglycemia. NKHH means non-ketotic hyperosmolar hyperglycemia. So replacement therapy should be given within 24 hours after admission. 50% of the deficit in first 4 hours should be administered, and 50% of the other deficit next up to 24 hours, guided by ongoing clinical evaluation. For children and adolescents less than 20 years, fluids are given as 10 to 20 ml per kg per hour in first 4 hours. Then we have to give as guided by the clinical evaluation. These are all the important bit points in the examinations. So normal saline, 0.9% sodium chloride should be given. It's available at all times, and rapid expansion of extracellular compartment can take place. Slow decline of extracellular osmolarity will be taking place. Slow rate of cerebral edema evolution will be there. Cerebral edema is the most problematic thing. So when we are giving this normal chloride, normal saline, there will be slow rate of cerebral edema. So normal saline is readily available. Rapid expansion of extracellular compartment is the facility. Slow decline of extracellular osmolarity is another facility. Slow rate of cerebral edema evolution is ultimate facility. And for every advantage, there is a disadvantage. It may accentuate the hypernatremia if already is present. And indications, all cases of diabetic ketoacidosis, and the initial first 2 liters in non-ketotic hyperglycemia. So standard low dose of insulin regime should be given, and it inhibits ketogenesis, and presence of insulin resistant state of secondary to stress insulin counter-regulatory hormones, ketone bodies, hemoconcentration, electrolyte imbalance will be there, hyperosmolarity and infection. So type of insulin, rapid or short-acting insulin, up to 40 to 100. Regime is initial bolus of 0.1 unit per kg body weight, IV. Maintenance is 0.1 unit per kg body weight per hour. IV infusion set can be given, or we can add 1000 units of regular insulin plus 500 ml of saline. Every 5 cc fluid contains 1 unit of insulin. Slowly we have to monitor. So all these things will be taught to you when you go into medicine. So IV infusion set is not available. You can give subcutaneous or immune dose. Initially, mild to moderate hypokalemia occurs in patients with diabetic ketoacidosis. Later on, after initiation of insulin therapy, everything will be correct. So monitoring is most essential. Blood glucose should be monitored by glucometer every hour. Urine analysis for glucose and ketone bodies, authorized test every 4 hours. We have to order IV glucose 5% if glucose declines suddenly, less than 90 milligrams. So rapid decline is not advised. So reevaluate the parameters of rehydration establishment. Stable blood pressure should be achieved. Normal urine output should be achieved. Clinical signs of rehydration should come. So evaluate the criteria for stopping hourly insulin regime when the diabetic ketoacidosis is resolving. So when the glucose levels are reaching just 110, 100, we are lucky. We can withdraw insulin and we can put him on oral anti-diabetic drugs. Acidosis is corrected clinically and by pH. Negative ketonuria and eating habits should be controlled. Patient looks good and feels good. So complications associated with illnesses are sepsis or myocardial infarction, adult respiratory distress syndrome, thromboembolism in elderly people, complications of treatment, hypokalemia, which may be leading to cardiac arrhythmias, cardiac arrest, respiratory muscle weakness, hypoglycemia, overhydration, and acute pulmonary edema, particularly in treating children with diabetic ketoacidosis and adults compromised with renal and cardiac function. This is most dangerous for people with pulmonary edema. So then we have to give Lasix again. So elderly people with incipient coronary cardiac left ventricular hypertrophy. So these are the diabetic ketoacidosis symptoms: stomach pain, vomiting, sleepiness, dry mouth, woody tongue, flushed face, fruity acidotic breath, and increased pulse. Remember this photo. This is a case, the female patient admitted to the medical ward, suffering from pain, right hypochondrium, and diabetic ketoacidosis. Age is 80 years, weight is 60 kilos. Family history is insignificant. Socioeconomic conditions poor. Vital signs: BP 130/90, temperature 101, pulse is 110. So the patient has objective evidence of pain in the right hypochondrium. Additionally, laboratory diagnosis is revealed ketoacidosis. So therapy should be given for treatment of pain in the right hypochondrium and at the same time for the management of diabetic ketoacidosis. And problem resolution is patient should be given electrolyte replacement therapy for the management, and we have to have a monitoring system. Blood sugar level and urine ketone bodies level should be monitored every 4th hour at least. The disease of the patient was not properly treated in this particular condition, so she was not given a complete treatment for the disease. Now, since we found out the problem, we have to put her on insulin. So thank you very much. We have to be a very good doctors in the future days to come.